Welcome to this webinar, a discussion of staging and multidisciplinary management of patients with early-stage non-small cell lung cancer. I'm pleased to introduce our moderator, Dr. Brendan Stiles, Chief of Thoracic Surgery at Montefiore Medical Center, New York. We're also joined by expert panelists, Dr. Biniam Kadanye, thoracic surgeon at the University of Manitoba in Canada, Dr. Matthew Bott, thoracic surgeon at the Memorial Sloan Kettering Cancer Center in New York, and Dr. Jonathan Spicer, thoracic surgeon at McGill University in Montreal. With that, I'll turn it over to Dr. Stiles.
Hey everybody, thanks so much for joining. I am super thrilled to bring this group together today to talk about this labor of love that this expert consensus panel has been. We decided that we would tackle staging and multidisciplinary management of patients with early stage non-small cell lung cancer, given all the emerging data on neoadjuvant, adjuvant therapy, and molecular testing. It fast became an impossible project as the field was really moving so fast, it was hard for the group to keep up with. Really, the three people you see here, Biniam, Matt, and Jonathan, are responsible for the lion's share of the work and really kept it going and did everything to sort of pull this thing together in such a fast-moving space. So I thought it was only appropriate that we talk to them about what this was like, what was good, what was bad, what worked, what's still controversial. The space is actually still moving fast. Actually, since we've even gotten this thing out, there's been a bunch of studies that have published that may change sort of what we think about some of these things. So that'll be interesting. I think this really should be a living document, a living expert consensus panel. But I think we should take the time to sort of go through some of the nuances of how we thought about this stuff and how it all came together. Obviously, there were lots of people to thank and lots of people deserve credit, but the three of these guys, again, did the lion's share. And I'm glad that they'll be able to describe it to you. I thought we should start like with any good panel and talk a little bit about the methodology. We don't want to bore you too much, but Biniam is our guy for that. And Biniam, I guess I'll start by asking you, did we do this right? Do we have the right people on the panel? Is it just surgeons preaching to surgeons, or how should we think about this?
I think we did it right. I think like most fast-moving fields with shifting evidence, it's very difficult to hit it right on the mark at any one time point. It's sort of a body of knowledge that's an evolution. So I think we approached it with good foundations. The major way we approached it is by having a committee of predominantly thoracic surgeons, or 14 thoracic surgeons, 2 medical oncologists. We did send our work out for extracameral review and feedback by external thoracic surgeons and external medical oncologists and radiation oncologists. And then we went back and retooled. But I think the one potential criticism of our work is that there wasn't an integrated radiation oncologist. And I think that it's definitely a matter of discussion. Beyond the actual composition of the group, the way we went through a process was actually quite robust and included a modified Delphi process. So now I'll go through some of the methodology, and please, at the risk of sounding very boring and long in the tooth, you please just stop me at any point and we can go back and forth about it. But we basically took a series of questions that were developed by the entire group, and we went back and forth trying to refine what were the important themes and important questions. And then based on that, we went back and we designed 3 themes, one of which was staging and diagnosis, the other was neoadjuvant therapy, the other was adjuvant therapy. And then we developed subgroups to that with subgroup leaders. And then we went and actually created answerable questions around those themes in the PICO format. So, population, intervention, comparator, and outcomes. And then we sent these questions to be researched or looked at by trained librarians with our feedback and input. And this provided an evidence base and literature that was specific to those questions. And then we looked at that and we did a modified systematic review type of assessment of the literature. And we came up with recommendations and a level of or grade of evidence associated with that recommendation. And then these were taken back to the groups, the subgroups, more voting done, more deliberation, more refining. And then we took it back to the overarching group and went through the same process through a modified Delphi process until we achieved consensus. Now, there were a priori thresholds for defining consensus. And then, the magic happened of multiple deliberations and we came up with our document. So that's the Coles Notes version.
Benham, it was really well done, and we appreciate your lead on that. If I could do it over again, I would have included some radiation oncologists on the original panel. I do think it was important to say that we got them out and reviewed. Our medical oncologists obviously played a big role in this too. And one of the debates we had, maybe I can ask John about this, is should we include abstracts? The space was moving so fast, we're getting hammered with abstract after abstract about new data, and there was a lot of discussion on the group about whether that's fair, whether we should wait for manuscripts. How are we going to think about this stuff in the future, and should abstracts be incorporated in these things, John?
Yeah, it's a great question. I mean, it's hard to move a whole standard of care from one paradigm to another just based on an abstract. But the truth is that our practice has been informed by these presentations, and the way we think about things is quite influenced by some of these presentations of the various meetings. So it did feel important to include them in some manner to be able to get a good appreciation of the fast, as you said, the fast moving pace of the literature and a sense of where things are going. I mean, I remember when we were having these discussions was in the months leading up to the Checkmate 816 approval. At the time, most of what we knew about preoperative immunotherapy was in fact from abstracts, and so we didn't want to create a document that was going to be out of date the moment it would be published. I think that ended up being a wise thing, because now it's coming out now, a little more than a year after we sort of completed the process that Binyam described. And so I think it's essential to stay on the ball with everything that's moving through abstracts.
Yeah, same thing, similar with lobectomy and sublobar resection, right? It was really tough and challenging. Right. One more question about methods and actually just about the purpose of it, Matt, right? So we really were careful to say this is expert consensus statement. You certainly are an expert, but not guidelines, right? And so I think that's important, right? But so how do, if we're putting this out there for everybody to look at, is it for every single time, every single patient? Is this just what we think should happen with the recognition that it doesn't necessarily always happen that way? What do you just think about that? Put on your philosophy hat.
Yeah, I mean, I think these aren't really meant to be sort of hard and fast rules, right? These are exactly what it says, sort of the consensus of a group of experts, quote unquote, that kind of establish what we feel like are kind of best practices, but it's not meant to be sort of narrow and binding. And you'll see if you read the document, I think for a lot of these things, there is a little bit of wiggle room, particularly as the data evolves and a lot of these things, sort of sentiments about a lot of the data and whatnot mature over time. So, I don't think it's meant to be rigid, but it certainly, I think, has already fostered a lot of conversation, for better or worse sometimes. But I think that's really the way that it's intended. So hopefully that's the way it's received.
Yeah, I think so too. I mean, it was amazing to read all the comments from everybody all the time, right? And every surgeon has different opinions, right? And so it's really hard to consolidate that.
Yeah.
Benny, what were you going to say?
Yeah, and I mean, I think not to be the obvious guy who's enamored with methodology, but I mean, and also I don't want to feel like
it's obvious. It's too late.
Yeah, I know. So at the risk of sounding like I'm worshiping at the altar of methodology, but I think to what Matt and John said, this is a fast-moving field, and the approach actually is very nice, because what it does is which is grounded on the AATS clinical practice document approach, as well as the grade approach out of the Hamilton group and McMaster. It actually is a good foundation of how to create a living document, meaning that we could very easily use the same construct and methodology to add as new evidence comes on and update this body of knowledge. And part of our approach is that we can actually incorporate the values and judgments that are sort of above the level of just the evidentiary sort of numbers that we see in the evidence.
No, I think that's a great point. And the Clinical Standards and Practice Committee is already talking about that, making this a living thing that will need to be updated as we go. And I think the ATS has really done an incredible job thinking about these things and how to position them across the range of our specialty. That was a good wrap up, Benim. I'm going to move on now to the sections. And so the first section was really about staging, sublobar resection, other stuff, and that was led by Matt. And Matt, I want you to sort of get us into the meat of this, right? And there's going to be sort of three things I want to hear about, staging. How important is pre-op staging now that we have adjuvant and neoadjuvant options? Adequacy of nodal evaluation, right? We got some heat for that. Like, do we always need 3 N2s and 1 N1 station for 6 millimeter ground glass nodule? Is that sort of ridiculous? And then what do we think of sublobar? Obviously, different data has come out as we've gone that sort of talked about equivalency. We had initially started saying lobectomy was still superior because we didn't have manuscripts, but now we have manuscripts. So hit those three things. So what do you think about molecular testing preoperatively and preoperative staging?
Yeah, I mean, I think, there are aspects of this section that are pretty straightforward. I think it are pretty universal, right? Everybody agrees on doing PETs and preoperative imaging and things now. So I think that was sort of unexciting, but we definitely got maybe a little, not controversial per se, but a little more controversial, I think, with the things you're talking about as far as how far to go with the node dissection question, sublobar versus lobar, and then the biomarker testing, I think, is a huge area of uncertainty just in terms of logistics, I think, for a lot of people right now. So those are areas I think that people will find maybe a little bit more interesting. I think the takeaway is in terms of, staging is critically important. Obviously, invasive mediastinal staging still certainly plays a role, regardless of the new treatment algorithms, I think, that are moving to the forefront. So those things are sort of still the same, but how you do your biomarker testing, I think, is impacted a little bit by some of this newer data, particularly in regard to the EGFR and ALK testing, right? We want to do that as soon as possible. So in patients who get triaged to preoperative therapy, we have that information available and we can use it quickly. So I think that changes people's workflow a little bit, right? I think in the past, everybody was doing that on the surgical specimen and they sort of kept that data in their back pocket. And if they needed it later, in the adjuvant setting, you can use it. But now it's certainly relevant earlier on. So we're working toward finding out the best ways to shift that earlier and earlier in the process. So we tried to make a point in the document that, as early as possible, ideally on the biopsy specimen. Obviously these are small biopsies, but with most of the technology we have now, whether it's percutaneous biopsy or robotic bronchoscopy, we can generally do that sort of biomarker testing pretty early. So I think that's important to keep in mind. The nodal recommendations in the document, we decided to keep in line with the Committee on Cancer recommendations, which were 3 N2 stations and 1 N1. And immediately upon presenting that data at the meeting, we started taking grief for it. So, I mean, appropriately so. We were sort of conflicted, I think, ourselves a little bit, right? Like, how important is that third N2 station sometimes? If you're doing a right upper lobe and you're taking a level 9 node, like, is that really helping the patient? And I think that's all very appropriate criticism in many ways. But, as people have mentioned since then, we're really trying to, set a sort of a high bar rather than setting the bar really low where everybody can, we can do it pretty easily. Let's set it a little bit higher and see if we can, generate some better outcomes by holding people to a little bit of a higher standard, I guess. So again, could that be in flux as some of the data plays out? There are a couple presentations at the AATS meeting a few weeks ago with folks talking about the relevance of 2 versus 3, or if you're doing 3, make sure that those 3 stations are applicable to the lobe that you're working on. So all of that information, I think, will be important. And to the point of this document itself sort of evolving as time goes on, those may be things that we update, sort of as we get more information. And then the sublobar versus lobar, I think that was very much a moving target, similar to the immunotherapy data that was coming out. The JCOG trial, I think there was like an abstract and a presentation for, and the CLGB data, I don't even think was presented yet. So we were kind of doing this with a forward-thinking mentality, and I think we had that data coming in. So we were trying to, again, be pretty accepting of that. And I think we as a field are still kind of incorporating that data into our practices. So we left, again, purposely maybe a little bit of wiggle room and said that, maybe for more concerning tumors, lobectomy is the standard, but, tumors that sort of fit those criteria, that segmentectomy or sublobar resection, is an acceptable alternative. So again, not taking a hard and firm sort of stance there, but definitely trying to be reflective of the data that's out there as people work on incorporating that more and more into their practices. So.
Yeah, those are great points. I mean, it really was. Surgeons get most passionate about these surgical questions, I think. And so I do think we got a lot of sort of feedback about that. And you could have gone either way, but I think you and your group did a tremendous job sort of thinking through this. I agree with setting the bar high, right? And I think we know that universally nodal sampling is underperformed. And so I don't have a problem with sort of saying, hey, we're going to right now endorse the Commission on Cancer Standards. I think expert surgeons probably know which patients they can do less on, but we have to remember this is for for a broader community. So I think that was important. But John, Benim, anything to add on these topics or sort of heartaches, things we should have done different or thought about differently?
Yeah, I was excited about your section, Matt. I thought it was exciting. No, but I think that's the purpose of this kind of work, is that there's even what I mean, we've seen now, we've both manuscripts are out and still people can't completely agree on what ought to be done. And speaking of the sublobar question, and inevitably we're asked to practice in areas where the evidence is a bit gray, and I think that was one of the tough needles to thread. It was to sort of not create completely vanilla recommendations. So perhaps make some recommendations that didn't achieve full consensus, or where there was exactly some controversy, but in the hopes that that would be helpful to the community, that where there is an absence or a lack of clear data to tell people that, well, this is what some folks who think about this a lot, where they align.
And then Benim, I'll ask, we've got two large trials that show equivalence, but is it going to be fair to chop it up into low and high risk groups amongst that thing, do you think? Or is that sort of bending the rules of a clinical trial?
Yeah, I don't know. Like, I struggle a lot with this because, to be honest, I was kind of practicing basically according to what these two trials have said for the last, since I entered practice, mainly because, from a Bayesian probabilistic kind of mentality, like there was an overwhelming prior probability that these were true. And so the threshold to accept it as truth was lower, right? And so but I also think that I think there's a lot of misinterpretation of this data by a lot of people. I think what they're taking it as, you should do wedges or you should do sublobar. Lobectomy is out. But what I think it's actually saying is that sublobar and wedge are okay in the appropriate people. That there are certain people actually where lobectomy is actually much better. And the data, when you look at the data, especially from the JCOG trial, it's quite clear who those people are. So I think there is a gap between what the RCTs are telling us and what we need to do at the ground level. And I think this is where, documents like this and Matt's section will help people. So I think in future iterations of this is probably we need to delve into a little more.
Yeah, I totally agree. And we need to remind our radiation oncology friends, right, that these patients got intraoperative lymph node sampling and then we're randomized, right? And so it's not just that you can treat anything with this and not have to think about nodes. So I think, great sub-analysis of all these things. And I think great and still interesting and probably one of the most important sections that we could have had. And so, Matt, I think you're exciting too. And so, keep your head up about it. It was a lot of work, I know.
Thanks, Brent.
Hey, let's talk about neoadjuvant, because man, that section was a headache. We kept having to wait. John kept saying, wait, something's going to happen. We're not going to hear something. Stuff's going to come out. And we finally closed the deal. And then just the last couple of weeks, we've gotten 2 new trials reported out. So John, what's the deal? Like, how hard was this section to do, and how's this going to evolve over time?
Yeah, this was really tough, right? Because some of us were aware of some data that was embarked at the time, and you think you have an idea of how people are going to receive it, but you're not necessarily sure. And again, Matt brought it up. You kind of have to let this stuff sit and see the data mature before you can really know exactly what you're doing. And to Binyam's points about how to interpret the results of trials, I don't think we're as accustomed to it as thoracic surgeons to sort of look into the subgroups and the forest plots and all this stuff, but that's like everyday stuff for oncologists who really do tend to dig into these subgroups and make treatment decisions, not necessarily based on the overall outcome of the trial, but based on some they'll pay more attention to certain endpoints more than others, and be even sometimes if the trials aren't really methodologically designed for that. So, and that's a lot of the discussion that we got into around the statements that we made. There were issues around the adequacy of data for the granular clinical TNM staging. Do we kind of do a catch-all approach for the application of Checkmate 816? What do we do with those scenarios that we face in clinic, or like a pancreas tumor? How do we retain data like a SWOG trial for chemorads in those patients? And do we take a position about whether to favor pre or post-operative treatment? Again, there, I think we kind of tried to take a position and have people vote on it. It was probably representative of a group of folks who work in very specific settings, and I think that's important to keep in mind. And again, I think the importance of this becoming a living document to sort of absorb these new pieces of data and maybe adjust some of the recommendations, say by stage or by molecular status, will become important. So we have 3 statements in there. They're pretty all-encompassing, and there's some language that might not suit everyone, but I think that it was the result of a robust discussion. William illustrated that nicely, and I'll be curious to see where it goes and how it's received by the community.
What do you think? I think we don't get much disagreement with clinical stage 3 patients, but clinical stage 2 patients, there's still lots of different thoughts about that. We didn't really strongly suggest those patients should get it, but should we have made that suggestion stronger? What do you think moving forward?
No, I mean, I have my own thoughts about it, but I do think that the responsible thing is that it's up in the air. I think we have to see more data, and I say it all the time, we don't have enough data about these high risk patients that we operate on every day, who the vast majority of whom just get surgery. Those are hard patients to study. The bar is a lot narrower in terms of seeing a benefit to adding extra treatment to these people, since we do cure a good proportion of them. So it's hard to say one way or another. I mean, I think the statements still stand true in the way they read, given the latest piece of data. I don't think there's any big changes in terms of my interpretation of it anyways. But there's a lot of new questions, do you give it before and after, and all that sort of stuff. And the stage 2 question will be a hotly debated one until we have really good numbers, or maybe trials that are almost entirely dedicated to those earlier stage patients who are always a little bit underrepresented, and we're always a bit underpowered to really make strong calls for those patients, at least historically and up to date. That's been the situation.
Yeah, and then the other topic that frequently comes up, of course, is neoadjuvant surgery versus chemoradiation and immunotherapy. We tried to kind of stay away from that topic, I think, appropriately, so that much data on it. But how do all of you see that question evolving over time? We're going to be able to do trials like that? Are we able to have consensus documents on that? Should we better define stage 3A, what makes patients resectable? Should we address the topic of resectability? A lot of people talking about that now. Thoughts?
That's a much bigger beast. Like, I think that could be a consensus expert document in its own right, honestly.
Yeah. And I mean, I think the way that things are moving, at least for those 3A patients, I get the sense that, there's going to be more and more interest in some sort of neoadjuvant, maybe, plus adjuvant component. So that sort of neoadjuvant versus adjuvant may settle down at some point, and we may end up doing both. And I think it's hard to tell right now till we have a little bit more data, but I think another sort of evolving space, we'll see.
Yeah, and then last thing, John, your section's already outdated, right, with the G and a neotorch. So any quick comments on those studies, or how they fit into your view of the picture for the viewing audience?
Yeah, it sounds like we need to get back to work, and get back in the Zoom room and start bouncing ideas. Yeah, well, there's a whole wave of new trials, right, that are coming out. AGN and Neotorch are just a couple of them, and there'll be 2 or 3 more at least. And then I think at that point, once we have at least a couple more of those out, we probably will need to sit down and think a bit about what all this means. And I think we'll have to be much more mindful of cost and toxicity as we go forward with this, and sort of be advocates for our patients. So not, I don't know who said this, but you don't want to turn your patient who could be cured with an operation into a super elite status frequent flyer at the hospital, for a very marginal benefit, and coming every other week to get infusions, and that's a big ask. And so I think we'll have to be quite conscious of that moving forward.
Yeah, and you think blood-based markers, ctDNA, minimal residual disease will get us there? We didn't really address that in this, but probably going to come up in the next one, right?
I think so. I mean, it's fun chatting with people working in the States where you have access to a lot of these things, and people are starting to use them. It's not really something that we have the means to use up here in Canada, but it's clear that it's on the horizon. In fact, a lot of people are already making use of these kinds of technologies. So I think it'll be kind of necessary for us to make a statement about it and understand how to use it. I mean, we've been sort of the custodians of surveillance for these patients for years, and I think that's an important role that we play, and continuing to play it effectively will mean more than just being able to read a CT scan and interpret its findings and communicate those to the patient. I mean, it'll involve counseling them about the pertinence of additional systemic therapy, perhaps prevention strategies to prevent the progression of existing GGOs and things like that, and also making use of technologies like ctDNA to better surveil our patients. So we'll just have to be much more conscious of all this stuff and know how to use them responsibly and to the benefit of our patients.
Yeah, go ahead, Matt.
No, I was going to ask you a question, Brent. So, considering now we have several induction immunotherapy trials with sort of different regimens, I guess, right? 3 cycles versus 4, neoadjuvant only versus neoadjuvant and adjuvant. So how, for surgeons that are in those conversations with their oncologists and are they're seeking opinions and things, how do you negotiate that? What's the sort of right approach? Do we know what the right approach is? When will we know? Sort of what's your take on where things stand as far as the optimal regimen at this point?
Yeah, great question. Tough question. I would sort of rely on Jamie Chaft, I think, once said that if we can give a patient 3 cycles, take their cancer out, and then send them out in the world and be done, we're doing society a great favor. And I really do believe that, right? If we can get it up front and not need it, that's the best. And so I sort of like a short cycle, so it doesn't sort of knock patients off for surgery, gets them to the OR, short and efficient. After, I think we'll change the right, probably depending on these markers that John just talked about. Clearly, there's some patients who will benefit from adjuvant. I'm not convinced we need to give everybody adjuvant for a year. But it's going to be hard to untangle all that stuff, I think, and it's going to be hard to compare different trials. And I think it'll be institutionally dependent. My guess is that oncologists will gravitate towards perioperative therapy, pre and post, right? And just naturally, which I understand. But I tell you, the patients love the idea of getting 3 and being done, right? You tell them you got to get it for a year afterwards, they're not so excited. But if you say, hey, we'll give you 3, they'll sign up for neoadjuvant, in my experience, every single time.
Yeah, definitely.
Well, good segue with all the markers into the adjuvant space, right? This should be easy for surgeons. We just do our job, we take it out, we stage the nodes, pass it on. But we still got a little bit of stuff here and like back and forth about this stuff, right? Benim and the questions like, adjuvant's moving fast, molecular testing should be easy there, but are we doing it routinely? Are we doing it on everybody selective? And we can talk about that first, maybe, and then I want to get your thoughts a little bit on 1Bs, right? We got some pushback. Should we send all 1Bs to oncologists, right? And we just saw the CLGB data from Nasser Al-Turki, and 16% of our patients are failing distantly, even with peripheral tumors less than 2 centimeters. 30% are having recurrence. So I'm comfortable saying 1B should see those people, but we got some pushback there. But how do we think about that? How do we think about testing? Probably, how do we make sure that patients can get their adjuvant therapy, right? That's a huge issue. Only half of patients, 60% of patients get all intended adjuvant therapy. So what did we learn from this section, Benny? What were the, the high points and the low points?
Yeah, I think I'll actually start with the last question you asked, which I think is there's a through line with what John and Matt said earlier and what Matt said earlier, which is about the stage 1Bs and about the idea of the marginal benefits of systemic therapy in these patients with lung cancer, right? Like, remember, we're dealing with lung cancer. And what really struck me was what John said about custodians of the surveillance. Another word comes to my mind: advocate, a steward. And so from my point of view, the question I think we have to think about is, who's defining what is a marginal benefit that's enough, that justifies treatment, cost expenditures and time? And is it the patients? Like, we don't, I feel like in many ways we don't bat an eye when people are expending or getting adjuvant therapies for breast cancer, which is, I think demonstrably a less aggressive cancer than lung cancer, right? So I think that should be part of the conversation about who's setting this marginal benefit, and should we be advocating more? Should we be engaging patients to say, like, is this something you're willing to undertake for this amount of benefit in terms of survival? So I think I'd love to hear your thoughts on that. But going back to what you were talking about, the adjuvant space, I think the biggest takeaway from our conversations was that many people don't make it to adjuvant therapy that should get adjuvant therapy. So historically, if fewer than half of the eligible patients are even referred for adjuvant therapy. Forget about get adjuvant therapy. So I think that's a huge area for improvement, and really that's at our doorstep. That's something that we need to own and get better about. So I think hopefully these kind of documents help to stir on conversations and learning from that. And in fact, a nicer, I think, evidentiary point is that another study showed that the greatest driver of completing adjuvant therapy was when a surgeon referred the person and talked to the person about it. So I think, we have a huge degree of agency as surgeons that we can really leverage. So I think those are the biggest points that came out for me. I think you mentioned what was your other question?
Yeah, the 1Bs came up, right? And so, should we say that to surgeons? And some surgeons really, I was surprised, were very adamantly against that, I thought.
But I think, is it really controversial to say that they should be at least discussed and referred to a medical oncologist? I think that's sort of the bare threshold that I would agree with. I mean, from a practice pattern in Canada, it doesn't burden the system a lot more to at least make a referral and get the medical oncologist to review the file.
Yeah, and I thought we were pretty careful about the language there, right? We didn't recommend they should get it. We just said they should have that discussion, really, as you said, drive it to the patients, like a risk-benefit analysis is really dependent upon the patient. And, a lot of that was in the context of, if you think about ADURA, for instance, right, we just had DFS. And so one question was DFS. Is DFS an important endpoint, right? And we didn't, OS is going to read out at ASCO in a couple of weeks. And so, well, no, we know by the press report that it was positive. But Matt, John, real quick from you guys, is DFS a good endpoint in adjuvant trials? And should we sort of hang our hats on that? Or does it depend on the patient, depend on the toxicity of the therapy?
Yeah, I mean, I think it depends on all of those things. I mean, I think it's a useful endpoint. Whether it's the best or not, I guess is a little bit debatable. But it's one of those things where, like, if you knew you were ultimately going to die of the disease, but you could be quote unquote disease free for longer, even though your overall survival was the same, is there benefit there or not? I don't know. I don't know the answer to that question, but I would view disease-free survival as a reasonable consideration, but again, not sort of hang our hat in that without, more meaningful sort of long-term data like OS. So I don't know that there's a right answer. I'm curious what you guys think.
John, I'm going to kick it to you for a second, right? There's a mental sort of craziness in Twitter cloud about DFS versus OS with ADURA. And everybody said, well, TKI, you're not going to see OS. And everybody said, of course, with immunotherapy, if you have a DFS benefit, you'll see an OS benefit. But so far in Empower, and pearls, we don't see an OS benefit, but it sounds like in Adura there's going to be one. So how do you unwrap that whole package?
We all love to be armchair quarterbacks or sitting sort of making our predictions, but I think both Benjamin and Matt made really good points. I think the value of DFS kind of depends on the disease. We have to remember, like, we're thoracic surgeons. We deal with thoracic upper GI malignancies that have really horrific outcomes. And when patients develop metastasis or progression, they usually are going to die of that disease. It's a little bit different in, say, the prostate cancer world, where more people die with prostate cancer than because of it, even when it will metastasize. And so I think the value of an endpoint like that kind of depends on the how aggressive a disease you're dealing with, and so even if the rationale that by giving adjuvant TKI, you're suppressing the disease, you're not really curing people, you're just kind of deferring ultimate progression. Well, if you do that long enough for a disease that is lethal, you're going to prolong life, and you're going to prolong overall survival, not just disease-free survival. I'm sure you guys have had patients with EGFR mutations prior to the osimertinib era that you'd find out that they had a craniotomy because they came into the ER with a stroke or with lateralizing symptoms, and this sort of stuff just hardly ever happens when they're on treatment. So I think it really kind of, the value of the endpoint itself depends on the disease, how it manifests, how it affects patients. And in the context of lung cancer, it's no question it's an important endpoint.
Yeah,
And
I think sometimes you have to like take it out of the sterile environment of the trial environment, or physicians talking to each other, and think about it as a person, right? I mean, do you think if you got a pill and it stopped you from getting brain mets, like even if it's just preventing it for another 3 years, another 4 years, another 5 years, like how can that not be good? How can that not be like important, right? So I think that's like another piece of it which we're missing, is the quality of life and patient perspective on it. But I think sometimes it helps to kind of take it out of the abstract and into the real.
Hey, so Benjamin, speaking about
those
that,
things are hard to quantify, I guess, though, right? Like those don't come through in a study. That's something that you just have to sort of empathize with the patient, their situations. It's more difficult to work into the conversation, I think.
So we tried not to touch that third rail of radiation therapy, but we had to talk a little bit about port in the adjuvant section, Benjamin, and mostly because the lung art trial came out right. And again, I think this is where we could have used some radiation oncology guidance, but I think we really got good feed in as we sort of modified that section. But any thoughts on that? And I thought we were pretty careful to say that could still be considered, right, and sort of confined to the context of that trial. What do you think, or any suggestions there?
Yeah, I mean, fortunately for us, there was some really good evidence to this effect, so it was some insulating factor there. But I agree. I think that both the lung art trial and the port C trial out of China were quite consistent in their findings. Like one of the limitations was that, and criticism of those trials, more so for the lung art trial, was that they were using more antiquated radiation techniques. They were using intensity modulated radiation therapy, or IMRT. So that perhaps could have changed some of the balance of risk and benefit. Probably not to a huge degree, but there's a possibility. I think this actually plays into some of the questions about the place of radiation therapy in neoadjuvant as well, like a neoadjuvant versus adjuvant. What are we using it for? And so there was a lot of debate about, whether we say neoadjuvant chemoradiotherapy or chemotherapy or chemo IO was preferable. And the question was, if a person is resectable up front, what is the additional benefit of radiation therapy above, for example, neoadjuvant chemo IO? And then in the adjuvant setting, where you've had R0 resection and it's N2 disease, what is the value of radiation therapy? Is it to try to mop up residual mediastinal disease? and the evidence really hasn't borne that out. So I think that we were careful not to overstep in our conclusions, and our conclusions were that it's always a good idea in certain scenarios to seek radiation oncology opinion, but the evidence does not support routine use.
Yeah, great points.
Can I add one thing on that? I mean, I was surprised that there was pretty unanimous support for the phrasing of those guidelines, only because, as I talk to more and more people, I feel like there is pretty liberal use of radiation at many places, and it's very much institution dependent. Maybe we just had, a group of institutions on the committee that were all sort of aligned, but maybe this is one of the more actual, like, practically useful recommendations to sort of get people more in tune with maybe not using quite as much RT. And again, just to echo what Biniam said, we're not saying not to use it at all. We're sort of saying more of a selective approach, which I think is probably appropriate. But again, maybe a guideline that we as a committee sort of took for granted, but may have some real, I think, practical utility out there as things move forward. So.
Yeah, that's a great point, Matt. And I think, hopefully that's the real purpose of this document, right? To get those things out there to others who aren't necessarily thinking about it all the time like we are, or most of the time. But so let's start to wrap this thing up. I'm interested to hear your closing thoughts. And again, so indebted. It was a huge team, multidisciplinary group, but lots of surgeons from all over the place doing this. But really, the three of you guys drove this thing home and really drove each section. So I'm interested to hear, what you learned and sort of take home messages and what you're looking forward to in the future. And we'll go by sections. I'll put you up first there, Dr. Bott.
Yeah, I mean, I'll just say that I think it was a great effort, and I was really happy to be part of it, despite taking a lot of grief from the rest of the committee, but that's all good. But I think in my mind, it was like a great time to do this and a terrible time to do this. I'm glad it worked out the way that it did, because there's a real need, I think, for kind of a summary of evidence-based practice at this point. It's just, again, in the context of so many moving targets, you realize sort of how quickly things are really progressing, which is great for our patients, I think, right? We're getting more and more data seemingly by the minute about how to treat patients better. But again, a little sort of overwhelming in a sense about how frequently these types of things will probably need to be updated as we make more and more progress. So yeah, I think it was a great experience and hopefully of value to the community. So thanks again for having me involved.
Awesome. Sorry, I was muted. Thanks for the hard work, Matt. John, what do you think?
Well, it was a lot of fun. I learned that although Matt looks very serious all the time, he's actually really a fun-loving guy. And Biniam, we've known each other for a while, and I learned a tremendous amount from him, from a methods perspective, and the whole group, right? I think that the most valuable part for me to participate in this kind of thing is to hear all the different perspectives on what is seemingly the same data set, and to understand how it's impacting various people's practice. The most fun was to sort of embrace the controversy and to be okay with having disagreements about various things that where we simply are trying to do our best and kind of bring our own perspective to the data, and so I think that exercise was really fruitful in that regard, and I think we'll have to do it more, fortunately, and I think it'll be good to get even more perspectives, more different disciplines and stakeholders into the discussion.
Yeah, great points. Vinny, what do you think?
Yeah, I'd like to echo all that. It's really fun. Learned a lot, and I also learned that John Spicer can really keep embargoed secrets very well. Like he was Johnny Tight Lips most of the time. We were really trying to squeeze him for something to lean us one way or another. And I mean, when you read the document, sometimes it may come across as like being written by a two-headed beast, or both heads of which were not communicating with each other, because our new adjuvant section and adjuvant section presumably seem to recommend both approaches.
Yeah.
So it's a bit frenetic in that way, but I think, as we're looking at the release of the new evidence, I actually have become much more of a neoadjuvant proponent that way. Thankfully for all of us, this debate is going to be thrown asunder by the fact that now peri-adjuvant is going to be probably the preferred route. I'm really excited about the new evidence, and I am really excited about the process that we've established and where the data is going to come or going to go.
Yeah, it was really an awesome effort. And, I really thank the ATS for doing it, the Clinical Standards and Practice Committee for sponsoring it, for putting this group together. And I just wanted to read out all the authors because they did all do a ton of work. And so in addition to Biniam, Matt, and John, who are here, Leah Bacchus, Jamie Chaff, Neil Chudger, Yolanda Colson, not that she didn't have a lot to do with the ATS this year, Tom D'Amico, Elizabeth David, Jay Lee, Sarah Najmi, Boris Sapetchi, Catherine Shu, Jeffrey Yang, Scott Swanson. And so, so many people from so many different institutions all contribute. I think it really made this a good document. I hope that people will use it and really read it widely. And so I hope that we'll get it disseminated. I think, having something like the ATS behind this will add a lot of weight and strength. And I think it'll open up excitement to do more of these. And so I hope we'll continue to do so. It was a lot of fun, man. I learned a lot. I like embrace the chaos, John. I think you said that was a good thing, right? It was a chaotic time for this, but it's a time that I think surgeons really should play a lead role, right? We've got to be an active voice. We've got to know this data, know this space. And I think, maybe Benham, you said, right, we're advocates, right? And I do think we often are the ones who shape the patient journey. So I'm happy to see this get out there, and it was super fun to work with all of you.
But Brendan, you forgot one person who was probably one of the biggest and most important drivers of this, which is Brendan Stas.
Well, I thought you were going to say Jill. So Jill, Jill did all the work. And so, we should thank Jill and the ATS staff who really did everything and kept us going on all this, right? And, incredible effort to put something like this together. And we're just one of many that they're putting together. So thanks to all them, and thanks to the sponsors. It's just really good to get it done. And gosh, I can't tell you how many times I've had people say, when's the paper come out? When's the paper come out? Finally, the thing will be out there and we're done with it. So thanks everybody for all your contributions, and really, really awesome effort. Can't wait to see
Thank
you
you,
guys.
Brendan, for your leadership.
Yeah, I can't wait to see you guys in person. So looking forward to it. Thanks for joining for this.
Right.
Take care.